This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
I'd like to welcome the California Podiatric Society for being here. I think you guys make your presence here makes us better. I want to thank Mike and Alex for their work on today's schedule and event, and it's been excellent so far. So we've kind of taken it from a reductionist standpoint of the foot. We went up to the limb and the staging of the limb, and I'm going to take a little bit higher view and looking at the entire patient. I think you'll find as we go through this that they're really tied together very, very closely. So this is the fate of a CLI patient. This will be my shortest talk, I think, because we really know already that the fate is not good. 5-year mortality for CLI higher than most common cancers. As you can see here, critical limb ischemia and prostate, breast, the whole spectrum of cancers there. Why that was before the disclosures, I'm not sure, but regardless, looking at just the competing risk of having amputation or even having a revascularization to remain patent is really death. I mean, death is the big competing risk for all these events in this patient population, which is so vulnerable. Looking at just the veterans population, because I work in a VA system, I'm always interested in that. And this is 4,000 patients that were done. And if you look at the overall survival, you can see it drops off pretty precipitously. But major amputation after tibial bypass, major amputation after femoral popliteal bypass. We don't have it all figured out, and this is a very challenging patient population to operate in. Most alarming is 3,642 patients produce 17,000 hospital visits. So one thing the VA can do very well is track resource utilization and how people move through healthcare systems and what forces drive which motions. So a lot of resource-intensive patients here. 1,500 patients were admitted 5 times. 1,000 patients were additional bypass grafting. So it's an ongoing endeavor when you have a CLI patient or any PAD patient. Really, it becomes a marriage between you, as Cameron Akbari told us last year. 5-year survival after above and versus below knee amputation. You can see here. It's really quite grim, and the best money is up front in prevention all this from happening. And I'll speak to that in a little bit. If you take a patient from the nursing home, they're going to stay in the nursing home, and you're going to do very little good. This is a paper that came out in JAMA Internal Medicine, and you can see that you're really not affecting the course of that patient, but you may relieve pain, and that's worthwhile, and you may help them ambulate or at least transfer, which is very worthwhile. But you got to be realistic, and you got to set expectations ahead of time with that patient and with that patient's family, and that's the biggest thing I do, and I think that we need to do is a very practical setting of expectations of what they can expect from the revascularization procedure. Mike talked about this, and I'm not going to go into it in any detail. There's a scorecard, and it's really kind of intuitive. You don't need a scorecard to say dialysis is bad and tissue loss is bad and being old is bad. We know that already. Thank you. But what it does is it allows us to compare apples to apples and oranges to oranges. So that's what these risk scores really do. What they don't do is they don't capture the biochemical flavor of the patient. They don't capture what's in the milieu and what's driving this. And we think it's inflammation. We think it's a cytokainemia. You can look at 2 inflammatory factors here, IL-6 and tumor necrosis factor alpha receptor 2. They are much higher in PAD than they are in heart failure. The reason I say that is because tumors produce these cytokines and create this system, and it creates a sort of catabolic state. And they're in a metabolic catabolic state, and that's where we might be able to intervene. I'm not sure, but it's worth investigating. And you can see that perhaps you could even call it a vascular type cachexia on some of these patients. Overall, if you look at just total cholesterol, you think CLI, they got PAD, their cholesterol should be higher. Well, it's not true. Because of this metabolic catabolism, they actually have lower total cholesterol, and this is statins, no statins, it doesn't matter. Lower total cholesterol and lower LDL. What does that mean? What is LDL good for besides giving us heart attacks? Well, it's very important for fighting LDL LPS for bacteria, gram-negative sepsis. It buffers that and it protects the kidney. Joe Rapp actually is one of the first people to describe that. So this low LDL makes them susceptible to infections and further immunocompromising the patient. If you look at the cytokines and compare just critical limb ischemia to patients with claudication, so within PAD, it's a great discrepancy. 2.7, looking at IL-6 down here, you see 2.78 versus 6.7, CRP 1.8 versus 5. And MCP1. All of them greatly elevated in CLI just compared to PAD. So it's a whole different, we're talking about orders of magnitude. If you want to talk about prediction, we can use age, we can use diabetes and renal failure and CLI, and we can kind of determine, discriminate between one patient who might die and one patient who might live. But if you start to include some of these other factors that we've been talking about in terms of albumin or CRP or the inflammation burden, you get a much better and robust score of discriminating who's going to do well and who's going to do poorly. I can tell you that albumin, CRP, and EGFR, there's nothing stronger than that I can find. We've known albumin has been a very strong predictor of outcomes ever since we've been doing surgery. I think the VA has been very instrumental in that. Well, what about the Wi-Fi? This is just some metrics I took out of a paper that Mike wrote recently. And if you look at minor amps, and at the left you'll see Wi-Fi 1, Wi-Fi 2, Wi-Fi 3, 4. These are stages of Wi-Fi. These are progressively increasing stages. And so if you look at minor amps, they go up as the Wi-Fi stage increases, as you would expect. BTK, below-the-knee interventions, again, it goes up, revascularization, and end-stage renal disease. The end-stage renal disease should say it all, because we know patients with end-stage renal disease do not do well, and it's a stepwise progressive increase as you go through Wi-Fi stage. And this is a paper that I wrote a long time ago saying a lot of the same thing in terms of the patients with higher levels of CKD, with CKD5 being sort of end-stage renal disease, you get higher percentages of gangrene compared to claudication. Also, you descend down the limb on your distal target of your revascularization, and then here's your survival curves for survival and amputation-free survival. CKD, higher levels of CKD and end-stage renal disease create more amputations and create more deaths. So what can we do about CLI? Well, I think we have better metrics and better classification schemes, not just predictive, but ones we can do something about. And there's questions I have. Can a metabolic or nutritional intervention improve outcomes? Can reducing frailty? There's a thing called rehab, how about prehab? Patients going and conditioning prior to any kind of intervention if time allows. Strength training, CLI CrossFit. Marlene Granon is interested in doing something like this at the VA, and I think we're going to pilot a little project. VO2 metabolism. I've always wanted to do this myself with a metabolic cart, but I just haven't had time and haven't had a chance. But I think that would be a very interesting endeavor. And a reduction of systemic anti-inflammatory burden, I think, is also key. I think our approach to CLI is too fragmented, and too many providers are operating in therapeutic silos. The limb is totally and inextricably linked to the patient and their health. Our approach needs to be more holistic, taking into account the many dimensions of the condition, including the ones I've talked about. And revascularization is really only the beginning, and we spend all this time at these different meetings talking about how to get tibial access, how to do this. It's really only the beginning. We need to think about the entire holistic patient as a whole. So thank you very much. That's the fate of the CLI patient. Happy to answer questions afterwards.